Okay, today we're going to be talking about SVT, and this is actually the second video that I've put out. So if you haven't seen the first one, that kind of lays the groundwork for this one, and that one is in the S drive under Red October under 2017. So watch that one first because this one starts to get a little more in-depth. Like I said earlier, we're going to be talking about SVT, but because we're transport, we're going to get much more in depth than just what is SVT. We're actually going to see what's happening within the heart, and we're going to talk about AVNRT and AVRT. And by the end of this, you'll understand what I'm talking about. So let's go ahead and get started. Before we get started, I just want to go back to how the heart beats. And so I'm going to be talking about its conduction system and how that conduction system relates to how the atria and the ventricle are going to contract. And so when we're talking about that, hold on, let me get the pen. When we're talking about the conduction system, we need to know a couple of things first. And that is that the conduction system itself runs throughout the heart. It runs through all these tracks that you see here. It runs through the AV node. And it runs cell to cell in all the muscles that you'll see in the heart. Now, because those are all different structures, it's going to run or conduct through there at different rates. And so what we have here is, if I use these Purkinje fibers or the bundle branches, you'll see that that electricity is conducted through there at the fastest rate, and that's because it has to get through the entire ventricle so that the ventricle kind of contracts in one contraction. And the ventricle is a large mass and a lot of muscle, and so this would be the obvious one to be the quickest. The second quickest is through these internodal tracts that you see here. And then the third would be the muscle itself, the myocytes, the cardiac muscle, where it has to go from muscle to muscle to muscle, and so that's located everywhere, and that's why I'm kind of drawing them everywhere. Everywhere you pretty much see pink. And then fourth, which is the slowest, would actually be the AV node, which makes sense because the AV node is going to kind of stall the signal, if you will, so that the atria have time to contract so that blood can go to the ventricles before the ventricles contract. So I'm going to go ahead and erase that. Now, another thing that you have to understand is that the atria are isolated from the ventricles, and I've drawn this red line here to show that. And what that's depicting is that even though the atria contract and they start propagating that signal from cell to cell, they have to stop here. They can't go beyond that point. And so what this does is this isolates the ventricles from the atria so that the ventricles don't prematurely contract. And the atria is now going to contract as one functional atria, both a right and left side. So what we're left with is just one way for the signal to come out, and that is through this AV node. So then let's just say what briefly happens. Of course, the SA node fires off. It sends that signal, and of course it's going to run quickest through these pathways, and then it's going to go muscle cell to muscle cell. Well, obviously it's going to get to the AV node before the atria have enough time to contract, because that's the fastest route in the atria for that signal to travel. So the AV node then is going to go nice and slow and hold that up and wait until the atria have all been depolarized with that signal, and then they contract. And then once that happens, the AV node will allow that signal to go forth to the ventricles, which will travel down very quickly, and the ventricles will contract. So we're going to kind of look and see how that happens here. So here I have the SA node. It is fired. That's the green part that you're seeing there. And you're going to see that the signal goes fastest down that conduction system. It's kind of like a street that it's just traveling much faster down than the actual muscle cells itself. Next, you see that here in blue, the muscle cells have started to depolarize. That signal has gotten to them. They've depolarized, which means they're starting to contract at this point. And of course, the signal is going faster down these conduction pathways. You'll notice I didn't do these two, and that's just because I just was kind of lazy and I didn't do them. But the signal is also traveling or propagating down those conduction pathways as well, if you can imagine. So then, as time goes by, more of the myocardial cells are depolarizing. And then we've got a large chunk of the atria. And then you see something happens here, that the atria, or excuse me, the AV node has already been stimulated. The signal has already come to the AV node. Now the AV node, like I said earlier, is to slow that signal down, because if you look, I've only depolarized this much of the atria. So what will happen now is that signal will then go nice and slow, and that's why I'm kind of drawing it like this. That signal goes very slow through that AV node while it's giving it time for the atria to contract. So during that time, the atria are depolarizing and they're contracting until you've got all of the atria that have actually contracted. At this point, all the blood that's left over that hasn't already fallen through will go from the atria to the ventricles. And then once that's happened, the AV node will release that signal and it will go quickly down into the ventricles. And so I've drawn these happy faces here, and what those happy faces are showing is they're just showing how quickly it's going to go through the conduction system of the ventricles. So let's just look at that now. And there the ventricles have depolarized. Okay, so now we're just going to jump into SVT, and we're going to be talking about AV nodal reentry tachycardia, which is a form of SVT. And just like the name implies, we're going to be talking about the AV node. So what I've done here is on the heart to the left, I'm just circling the AV node. And then from there, what we've done is blown it up. We've zoomed into the AV node of some individuals. Of course, this is not every individual, it's just people with the propensity to have SVT. You'll notice that on the heart, the entryway, or the coming into the AV node, will be represented by this pathway here. And then the exit from the AV node to the ventricles, that bundle of His, will be represented here. And that's why I put this is the atria and this is the ventricles. So basically the signal's coming from up here, and then it's going to, of course, go through the AV node, and then the signal will propagate and go to the ventricles from that point. Now you're going to notice something strange about this AV node. The first thing is that it doesn't look like this. We don't have an AV node that just goes from the atria straight to the ventricles like that. We don't have this, and that's what those black lines represent. What an AV node should be doing is just carrying that signal forward, or rather it's just going to bounce around in there for a while. But it's just one entry point and one exit point. We have something different. What we have is, if you notice, we have a slow side and we have a fast side. Now, looking at the slow side, which is represented with this red little emoji happy face, and then the fast side, which is represented with the green one. Looking at the slow side, basically what's going to happen is he's going to take that signal that comes from the atria, he's going to take that signal and he's going to move down his pathway down through the AV node. But he travels at a slower rate. And really he's not traveling at a slow rate, he's traveling at a very fast rate. He's just traveling at a slower rate than the other side. So it's really not that he's slow, it's just that he's slower than the other side. I put that this cell moves like a jogger, okay, because he doesn't sprint, he doesn't run, but he jogs. So he moves quickly, and because of that he can recuperate faster. And what that means is that if he gets another beat that comes, he'll be ready for it every time. He's always going to be ready because he recuperates so quickly. And basically what's happening is that tissue, or this area here, carries the conduction slower, but it repolarizes very fast, and so he can be ready for the next beat very quickly. Now if you look at the other side, the fast side, this is what I've put as the sprinter. He is going to move very, very quickly through here, but like a sprinter, he gets gassed out very quickly. He can't recuperate as fast. And so what happens is, if another signal comes and that signal's early or something like that, he's still going to be recuperating. And so what we're left with here is, if you actually look at this, is you basically have two parts of the tissue doing two different things, and this is what causes a re-entry loop, and that's why they call this a re-entry tachycardia. So let's kind of look at what's going to happen here. You're going to see that in a normal beat, the signal's going to come, and both of them will be ready because it's just a normal beat, and so the slow one's just going to travel and travel and travel, while the fast one travels and travels and travels. Of course, this fast one's going to travel at a faster rate. So what's going to happen is, it's going to come to this point here where it now has the ability to just go to the ventricles and the ability to go forward, keep going in that circular motion. And that's what it's going to do. While the other one, the slow one, is going to go nice and slow, and he's going to keep going, and eventually these two are going to bump into each other, and when they bump into each other, they kind of negate each other. So let's kind of look and see what happens. The signal comes, and they both go, and so what you see here is that these two have run into each other, and because they've run into each other, they cancel each other out. The energy, or the signal, has nowhere to go, and so the signal gets lost over here. But if you look at what happened, the signal came from the atria, traveled through the fast area of the AV node, and went down to the ventricles. And that basically is almost the same thing as if it would have gone straight through in a straight line, because that's the only signal that counted, because this one here doesn't count because they just ran into just ran into each other. So what you're going to see from here is normal sinus rhythm. We don't know, we don't see any of what happened on this side. None of this is shown on the ECG, because on the ECG, remember, the AV node is just this flat baseline here between the P wave and the QRS, that little PR interval, and it's electrically silent. So there's no waveform on that. So we don't see any of that. So we won't know if a patient that we're taking care of has a slow and a fast path. All we know is that they go into SVT. So let me go ahead and erase that. So that's great, but what happens if the person gets excited, the person has too much coffee? Then that sets him up for SVT. So let's just pretend that a premature atrial complex or a contraction occurs, and I'm just putting this area in red to say this is what happened. We have a beat that just started because this guy got excited. So he got excited and he had a PAC. PACs are normal for you, me, everyone. Everyone has PACs. But let's just pretend here. Let me go down to this rhythm here, and we're just going to say right here he got excited and he had this early beat right there. So instead of a long R to R interval like you see here, he's got a very short R to R interval here. And because of that, what you're going to find is that he's opened up this doorway to actually go into SVT, because he's going to travel that signal early. So let's see what happens. So if I take that and I come to this one over here, and let's just say the PAC fires really early, and I'm just putting it right here, and he sends his signal. Well, of course, like I said earlier, the slow pathway is going to move a little bit slower. Remember, I say he's a slow pathway, but he's just slower than the other pathway. But the sprinter, he just sprinted. He's tired. He needs to recuperate, and because of that, he's not going to go very far at all. He's just going to barely move, and he's going to be blocked at that point. And that's what this ERP means. That's the refractory period. What that's showing here is that he's not going to be able to travel through there. He's not ready. He has not recuperated, or that tissue, that side of the tissue rather, has not recuperated, has not repolarized, and so it can't propagate or send that signal down that pathway. And so let's kind of see what happens here. He goes, and then at this point he's stuck. He can't do anything. So his signal dies at that point. Doesn't go anywhere. While this one here has made it all the way over here. So what I'm going to do now is I'm going to say that he's over here, and we're going to keep going with that. Well, you're going to see that if he keeps going and he travels, he again comes to this area where he can go in two different directions, and that's what the signal is going to do. Some of the signal is going to travel this way, and the rest of it's going to go this way. So he's going to go in two separate directions. So let's kind of watch that. And now what we're seeing is he's over here. He's back on this, which is initially this side here that wasn't ready. So let's go ahead and take him, and now look to see what's going to happen next here. So he again travels, and now what's happened is he's stuck in this loop, because this area now is ready to conduct that electricity. He's going to keep going and going and going and going, and every time he comes to this point where he can go in two different directions, he is. One's going to go this way and then continue, this way, and some of that energy when he comes down here is going to split up going this way and go this way as well. And so he's stuck in this loop now, all because this area here wasn't ready. It was too soon. And so now we're stuck in this loop. So let's see what's actually happening when that signal gets stuck in a circuit. And so I'm going to go ahead and stop that because that can be kind of annoying. So let's see, we have the AV node here, and we have this signal that's going back and forth and is stuck in a circuit, and then of course every time it comes up here it's firing off into the atria, and then every time it hits down here it's going into the ventricles, right? So this keeps happening over and over and over again. Well, what happens? Well, think about it. Usually in the heart, the SA node starts that wave of depolarization and sends the signal in a downward fashion, and the atria kind of contract in a downward fashion. But if you notice here, the atria are now getting stimulated on the bottom to contract in an upwards fashion. So they're basically now, the atria are now contracting backwards, if you will, or upside down in a backwards fashion, from bottom to top rather than from top to bottom. So if you look at the SA node in the top to bottom, you'll see that the P wave, we have these normally upright P waves like that. Obviously, if the atria are being contracted opposite of that, the P wave is now going to look opposite. So you're going to have what some people call an upside down or a retrograde P wave. The QRS should look the same because obviously the ventricles are still getting stimulated through their normal system. So let's go ahead and look to see what it looks like on the ECG. So looking on the ECG, what you're going to find is that these P waves that are upside down, a lot of times they get lost in the QRS because the heart's beating so fast. They're sometimes in here, but they're hidden. Sometimes you can see them. This may actually be a remnants of the P wave here that you're starting to see that I've kind of circled right here. Those may be actual P waves that are upside down, or retrograde P waves, whatever you want to say. But most of the time you cannot see the P waves because usually they get hit at the same time, or they fire off at the same time that the ventricles fire off. So most of the time they're just lost within this QRS. Every now and then, and let me just draw it out really quickly because every now and then you can see them. Okay, what I've done is I basically drawn out sometimes what you can see, and if you notice these waves here, a lot of times those are actually those upside down P waves that you can see there. And sometimes you can see them and sometimes you can't. If you can see a P wave in SVT, it's usually abnormal. Most of the time you can't see the P waves, but if you can, just remember they may be abnormal. The QRS, of course, is going to look normal, like I said earlier. But one thing that we can do when we're looking at the QRS is we can measure this R to R interval that we see here. And so if I got calipers and if I measured the R to R interval, I should notice something. So I got the calipers and I cutting and pasting another pair and then cutting and pasting another pair. What I'm going to find is that the R to R interval should be pretty much the same. And what that's showing is that the rate or the conduction of electricity down this pathway doesn't really change. It stays the same. And that's what keeps this R to R interval the same. And so you should have in SVT, you should have a regular R to R interval. So what's happening during SVT? First of all, I've shown two hearts down here, one with normal sinus rhythm and one with SVT. In normal sinus rhythm, the beat starts, or the wave of depolarization starts here, goes to the AV node. The AV node waits, lets the entire atria contract. The blood then has time to go from the atria to the ventricles, and then the ventricles can contract. In SVT, everything's happening so quickly that the heart is not getting a lot of time to fill. Remember, the heart is filled during the diastolic time. During the systolic time, it's actually pushing the blood. So during diastole, the heart is filling, and because SVT is causing such a tachycardia, the heart rate's so quick, you lose that diastolic filling time. And as you keep losing diastolic filling time, what's going to happen is the blood in the ventricles and even in the atria are going to be less and less and less. So I'm losing out on this, what they call preload. And so with time, that's going to cause some problems. If the patient's very healthy, it may take days for an infant to actually show signs that he's in any kind of compromise. He may show up in CHF, but it may take him days just because he's got a very healthy heart. Those are those infants that come in and they're trouble eating, poor appetite, they're breathing kind of funny. You listen to them and they have a very fast heart rate. What's happened is slowly over time, this amount of blood wasn't enough, and because the heart's kind of like a rubber band, it squeezes harder with more fluid in it. It's lost that squeeze, so it's lost that cardiac output, and blood starts backing up in places, and one of the places it likes to back up, of course, is in the lungs, so they go into CHF. The older patients, of course, a lot of times they can feel the palpitations, or they may feel dizzy as they start losing cardiac output. Okay, that was AVNRT. Now we're going to switch over to AVRT, which is AV reentrant tachycardia. So this is not within the AV node. The AV node in this case just represents one pathway from the atria to the ventricles. Some people call this Wolff-Parkinson-White. Some people say just WPW. And what we're really looking at is if you can see that I've outlined again in red the division between the atria and the ventricles, you'll notice this band-aid looking thing right over here. And what that represents is sometimes muscle fibers kind of connect the atria and the ventricles. They've somehow gone through this insulation that's drawn in red, and they've actually connect the atria to the ventricles. And so what that represents is an accessory pathway, another pathway for that signal to go from the atria and the ventricles. So not only do we have the AV node, but we also have this accessory pathway. Some people call it the bundle of Kent. Some people have stopped using that because it's not just found in one spot anymore. Actually, most of the time it's actually found somewhere over here. And sometimes it could be in the posterior region right back here. So there's various places that it can be. I just wanted to put it right there just because it was a little bit easier for me to make the drawing work. So let's see what happens. We have the normal SA node conduction, and with that normal SA node conduction, you can see that in green it's starting to depolarize, and it's going to go ahead and send that signal throughout the atria. So the whole atria have received that signal, and that's why it's in blue. And of course the AV node is doing its job. It's letting blood go from the atria to the ventricles at this point. So it's kind of stopped it. But at that same time, this area has been depolarized, and there's nothing to stop it. There's no AV node working on that, and so it's going to keep propagating that signal down to the ventricles. So let's see what happens there. It sends that signal, and it starts depolarizing an area within the ventricles. This area here is depolarized from cell to cell, muscle cell to muscle cell, has sent the signal, it's carried it, and basically this part of the ventricle is now contracting, and that's why they call this pre-excitation or a pre-excited ventricle. It's because some of the ventricle went ahead and started to contract before the signal was given down the normal pathway. And so if we look at the ECG to the right, and I'm kind of going to draw what's happened here. Remember this PR interval here? This is during the AV node time. So I'm going to draw it right over here. So we lose some of that time because the signal keeps going, and that signal comes up to the rest of the QRS, because what's going to happen is the AV node is then going to release that signal, finish with it, and then it's going to travel so fast, so quickly down the ventricles and through the ventricles that it's just going to be one quick blow. And so the ventricles are going to really do the rest of the depolarization their normal way, with the exception being this area that got pre-excited. And so if we were to look at this QRS, you would say that this QRS, which I've changed, looks just like this one here, and that this part here is actually called a delta wave. So when somebody refers to a delta wave, what they're referring to is that pre-excitation that happens through this accessory pathway that depolarized this area of the ventricle. So when you're seeing a delta wave, now you've got to worry about a patient who is susceptible to tachyarrhythmias, not just SVT. That's just one of the tachyarrhythmias that they can go into, but there's other tachyarrhythmias as well. Sometimes what happens is some tissues, some of these accessory pathways, they don't conduct this way. Some of them actually only conduct in one direction. They're called unidirectional. And what if this one only conducted in an upwards fashion? If this one only conducts in an upwards fashion, which is in some people, a lot of people it can conduct in an upwards and downward fashion, antegrade and retrograde. So it just depends on the individual. But in certain individuals, it can only conduct in this fashion. And because it can only conduct in this fashion, it won't let that signal go this way. So you won't get that pre-excitation. And their ECG is going to look like normal sinus rhythm. And that is actually called a concealed pathway. So sometimes you may hear a cardiologist talk about a patient with a concealed pathway. What they're saying is you're not going to see this delta wave here because there won't be any pre-excitation because it only transmits the signal in an antegrade fashion or upwards, and so you won't be able to see that. And so there's going to be a percentage of people that have Wolff-Parkinson-White that we're not going to know that may go into SVT. It's still okay as long as they're in SVT. We can still use adenosine. There has been a misnomer from a long time ago that you couldn't use adenosine with Wolff-Parkinson-White, but you sure can as long as they are in SVT and not some other arrhythmia. Okay, there's two types of AVRT, and that's why I've got two hearts here. With both of them have the, of course, the accessory pathway here, and of course the accessory pathways here. We're going to look at the one here on the left part of the screen first. And in the left part of the screen, what I'm showing here with this green emoji is the pathway that happens with what's called an orthodromic. And this emoji just happens to be, again, another premature atrial contraction. And basically what happens is a premature atrial contraction comes early and it fires off and it goes throughout and it goes to here. But we're going to say that this region, this area, this accessory pathway isn't ready yet. It's still refractory and it won't allow the signal to go through this way. So the signal is only going to continue going this way. And of course it's going to go to both ventricles, but I'm just going to draw it going to this right ventricle. And we're going to say that once it gets to this area here, it is now ready. And so it will keep conducting. It'll continue. And as it gets to the atria, it can go in all directions, and it'll again go back to the AV node. So then basically what you have now is again very similar to what we saw earlier with the PAC causing this to get into a reentrant loop, and it'll go around and around again and again and again and again and again. So this is kind of a picture depicting the same thing. It's just going round, but it's going in a clockwise fashion, and this is called orthodromic AVRT. And if you look at it on the ECG, it just looks like regular SVT. So basically, we can't tell the difference on looking on an ECG whether it's orthodromic, AVRT, or AVNRT. We're not going to know. Now, there's also another one called antidromic. And in antidromic SVT, it's just the opposite. PAC will hit. It'll come early, and in this case, the AV node's not ready. So it'll fire off this way. And so what we've got is it traveling through this direction and going up and back over in this way. And it's going to keep going over and over and over again. And like I said, this is called antidromic, but notice something. It isn't going the same way through the bundle of His and everything else. So you're always going to have this pre-excitation. You're always going to have what we were talking about earlier, these delta waves, but these delta waves are coming so quickly. And so what we get are these really wide QRSs. See these QRSs that are downward? Getting very wide QRSs. because it's not going down the normal conduction system that it was earlier. And so this actually looks a lot like VTAC. And because it looks like a lot like VTAC, we have to make sure, and this is where it becomes very necessary, that when we have VTAC, because the American Heart Association has now said that it's okay to give adenosine for a stable monomorphic VTAC, a stable monomorphic and regular VTAC, that we have to make sure that it is regular, and that's really the most important part. It has to be regular. We have to have regular R to R intervals. If we don't have regular R to R intervals, do not give the adenosine, because this could be something else and we could actually throw them into VFib. Okay, last, we're just going to talk about how to treat SVT. And I've only put 3 ways. We know that there's other medications that you can give. Sometimes the cardiologist may order amiodarone drip or a sotalol drip or something like that. I didn't put those on there, but I put the ones that we usually use. So obviously, if the patient is doing well, they're not hemodynamically compromised, they're cooperative, they can listen to you, then you can ask them to take their hand and blow on their thumb as hard as they can. And what you're trying to do is vagal them. Say, blow as hard as you can, as loud as you can, and pretend your hand's a trumpet and just blow hard, and hopefully then that may actually get them out of the SVT, because you're actually using the vagal nerve, which innervates both the SA node and the AV node to slow that signal down. Of course, we can retry that again if they're still stable. If it's a baby, we already know, use the ice to the face. Of course, you get some ice and water, put it in a bag, and just make sure you have a good slush of it. It's not just all ice, it's just really a good amount of water as well. And then quickly, without the patient knowing, you go over the forehead, and you're trying to induce 2 different things. You're either trying to get them to cry because of surprise. All of a sudden they have something very cold hitting their forehead and they're surprised, and when they do that, they're going to let out a cry, but before they cry, they hold their breath for a while, and that hopefully will vagal them. And if that doesn't work, we're hoping that maybe we get a little bit of that mammalian diving reflex, that reflex in animals when they go into the water and they have to go down and get some food or something like that. When they're above water, they go down, and as they go down, their foreheads hit that cold water, and when that happens, there's this reflex that happens to them that slows everything down. So we're kind of hoping that that may happen to the child as well. Infants and even children have had that reflex. As a matter of fact, there's been cases where it was a 6-year-old boy, I believe in Michigan, fell into the water, and because it was icy water and his forehead hit the water, he went into what they believe was a mammalian diving reflex, and he was actually underwater for like 66 minutes and was able to leave the hospital walking out. Other things that we can use, of course, are adenosine, and we know the dose is 0.1 milligram per kilogram is the first dose with a max of 6 milligrams, and then you just double it. So it's 0.1, double it to 0.2. So our maxes are 6 and 12 for our first and second doses. We're very familiar with that medication. And then, of course, there's cardioversion as well. 0.5 to 1 joule per kilo on the first dose, and then 1 to 2 joules per kilo for the second dose. It's just easier to remember. Just use 1 joule per kilo for the first dose, and then double it for 2 joules per kilo on the second dose. Kind of like the adenosine, 0.1 to 0.2, and then cardioversion 1 to 2. And that's kind of like our last ditch effort if the adenosine's not working, or if the patient's hemodynamically compromised and you don't have an IV, then go ahead and cardiovert them. Otherwise, it does cause pain, and so we try not to do it unless we have to do it. And that's going to go ahead and end this one. I thank you guys for watching.